Simulation Health Project, Suicide Prevention by Connection by Jennifer Marquez. My name is Jennifer Marquez, and I'd like to talk to y'all today about a topic that's near and dear to my heart. My population is adolescents aged 12 to 17 at risk for suicide and self-harm. Youth in the school age range sometimes lack the ability to cope with negative pieces in life events. Suicide is the second leading cause of death for this population. So why is this population at risk? Many factors, including problems at home, bullying in school, genetic predisposition to mental illness, economic factors, substance abuse, decreased access to care, sexual orientation, peer pressure, and decreased self-esteem are all determinants associated with poor outcomes for our youth. Here are some statistics related to suicide nationally and specific to Washington State. You can see here that 18% of our 10th graders have had self-harm thoughts. This is heartbreaking, not only to me, because this is my daughter's grade, but also her friends and sports teammates are all at risk, and the numbers tell me that some of these kids are having these thoughts. 1 out of 5 of this population admits to self-harm thoughts. 1 out of every 10 have attempted some actual self-harm behaviors, such as cutting or taking over-the-counter medications. Access to mental health providers in Benton County, Washington, the numbers are staggering, 620 patients to 1 provider. For my community assessment, the chosen model for assessment and screening in the community was the community health assessment and group evaluation. With the change model, we can use it to accumulate information and create programs and tools focused on healthcare issues of adolescent suicides, and evaluate the planned programs periodically and make changes and track prevalence of self-harm behaviors and actions. With our change model as framework, we can distribute screening tools like the Columbia Suicide Severity Rating Scale into our community through local middle school and high schools. High-risk behavior screening, including drug and alcohol usages, provide screenings in Spanish and English, use the data collected to get real assessment of the community's mental health status of adolescents. With change, we can utilize schools and family practitioners. The Columbia Suicide Severity Scale will give us feedback needed and also pinpoint locations and areas in the communities that might have a higher severity score and offer more resources to the affected communities. Based on our community assessment, the following community nursing diagnoses are appropriate for this population. Risk for interrupted family processes. Problems at home can often drive unfavorable health outcomes for the youth related to loss of a family member, divorce, or abusive behaviors, as evidenced by 30% of our kids in single-parent family homes and 21% of children living in poverty in Benton County. Risk for suicide and self-harm behaviors related to high volumes of youth with suicidal ideation within the community and state of Washington, and identified determinants in this population as evidenced by higher than national average suicide rates in Washington states. Ineffective health maintenance related to the less than favorable amount of mental health care providers located in Benton County, Washington, as evidenced by the 620 patient to one provider ratio in the county. The Healthy People 2020 objectives, which align with suicide and self-harm prevention, are closely related. If we could continue to build on these objectives and make our focus for this population, it could lead to a better healthy outcomes for the youth. Increase wellness checks for this population, increase parental involvement in adolescents' life outside of home, decrease the number of absences in school, decrease the availability, selling, and use of illegal drugs in schools, decrease bullying and sexual harassment, decrease victimization of adolescents and youth from crimes and violence, increase adult connectivity and provide youth with someone to share their serious matters. So our proposed interventions, primary prevention would be to create a program in schools where teachers, counselors, and healthcare professionals give assemblies on suicide and prevention and self-harm. We could utilize social media, radio, infographics, and TV to promote healthy choices and behaviors, promote safe home environments with open communication lines, assembly on stopping bullying in schools and online areas. For secondary prevention, we can screen for suicide behaviors in schools and primary healthcare providers, educate parents and students on high-risk behaviors and the signs of suicidal ideation and where to report these behaviors. Opening the lines of communication within a family or community can be useful, and screening, the more youth can be engaged, the more they are willing to talk about hardships and negative things in their life. Identify substance abuse within the family, community, friends, adults, and the youth, and provide necessary resources to assist with management. So for tertiary prevention, we can provide multiple outreach and resources to combat helplessness, offer call centers for help, increase the number of mental health providers in the area, change prevalence of bullying in schools and online areas, and offer support groups. Things we need to consider with the interventions. Ethical issues to consider would be risk for loss of privacy, outreach to high volume of Native Americans in the area. Cost includes funding for staffing and phone centers, suicide by connection participants in school programs, educations for adults involved, TV, radio, and social media ads, getting parents involved and educated about the warning signs and risk behaviors without making them feel defensive or overwhelmed. Another cost would be education of school staff and healthcare providers, attempt government funding to combat youth suicide, and local public health offices. This is my logic model, and it talks about the interventions that we've already just discussed and what we expect to get out of these interventions. Our evaluation plan. We can evaluate our suicide prevention by connection program using the CIPP, or Context Input Process Product approach, as described in an article by Fry and Hemmers. Microcosting methodology will also be discussed. By using CIPP, or Context Input Process Product model, we will be able to evaluate the effectiveness of our suicide prevention program. The prevention program is created and constantly evaluated for areas that need to be strengthened and what interventions need to be improved upon. We will look at what is needed, what's holding us back, and whom we will recruit, and what kind of funding and assistance we will need. For input, we will need to evaluate how easily or difficult the interventions will be to move forward, and cost. For process, we will look at how our suicide prevention strategies and plan to infiltrate schools and communities translated to action. Did our plans roll out smoothly? How did our population react to our interventions? Was there a good acceptance of the program at schools? Did we meet our budget goals? Were there unexpected outcomes? And did the suicide prevention program meet the timeliness goals? For the product part of the model, we can further evaluate our outcomes. Was there a decrease in suicidal behaviors among youth? Did the resources available increase? Did bullying decrease? Are the parents, students, and providers more informed and educated on self-harm and suicide? We can also look at how the program worked and what didn't work. Along with our evaluation plan, we will need to look at the cost effectiveness and budget. How did our commercials and ads work? Were they cost effective? How effective was our school program? Using micro-costing methodology, we can track and pinpoint the budget and costs of our program by taking each input and breaking costs down with high probability to match the proposed spending with actual spending. So for our call to action, let's decrease bullying, let's strengthen family bonding and trust, let's increase education in the community, mental health awareness, substance abuse use, increase the available resources in school and after school programs. With the creation of our Suicide Prevention by Connection program, we can help fight the determinants for youth suicide, including awareness for bullying behaviors and outcomes, encourage the family ties and strengthen home life to help deter helplessness in the home, educate the community, students, teachers, parents, and healthcare professionals on risk factors and risk behaviors, increase screening for mental health diseases, monitor community for substance abuse, and pinpoint problem areas, suicide hotlines, crisis response teams, and outreach programs to increase the resources available to the community. And finally, in our in-school and programs, we will make help readily available, educate, and provide the means to get the message across and make resources known to this population. In summary, suicide is a real problem for adolescents. Interventions in schools can help decrease bullying in schools, increase the parents' health care provider awareness, increase our resources, increase the number of programs dedicated to self-harm prevention, increase the number of mental health care providers in the area. With the proposed interventions in schools, parental and provider education, we could very likely see a reduction in the prevalence of self-harm and suicide behaviors. And these are my reference screens, and I thank you for your time.